I think we'll make a start. So as I say, welcome everybody. Appreciate, some of you have heard this many times now, but we do appreciate you joining this session. Before we start, let's do some housekeeping. So this session is going to be recorded and it will be shared with attendees afterwards. It will also be uploaded to our website and to our YouTube channel. Could you please make sure your cameras are turned off and mute your microphone just during the presentation? There will be polls used, as we've already highlighted during this session. These polls are anonymous, so as I say, we would appreciate it if you take your time to complete those. And then if you could add any questions to the Q&A section. We'll be monitoring the Q&A and the chat section, because I appreciate some of you using both, but the Q&A section is quite useful because if you see a question there that resonates with you, then you can like it and that will push it up to the top of the questions that we answer. Hopefully we'll have plenty of time for questions at the end, or depending what we get through this session. Lovely, thank you, Jo. So this session is the third in our series of Genomics for All, and we're looking at today practical family history skills for holistic care. So I am co-presenting today. My colleague Jo Hargrave here, thank you, Jo, is our lead midwife, and my name's Anita Murphy and I'm the lead nurse, and we work for the East Genomic Medicine Services Alliance. And this is what hopefully we're going to cover in today's session. So we're going to look at the importance of family history in genomics, reflect on some cases in practice, and then look at clinical application and practical skills. This session is designed to give you an overview of utilising family history in clinical practice. We will be signposting you throughout to further tools and resources you can access to support your further development. So I'm just going to go back to the poll because I know a few more of you have filled that in before we go through these. So let's have a look. Oh, lovely, thank you. Now it's interesting. Probably the most common one on there is coming up for me is risk, is showing actually. Risk factors, risk management are coming up as the most commonly sort of words used, and why is it important in taking a family history in clinical practice. So I'm just going to go through some of these on the screen to just elaborate a little bit more. So it will reveal a pattern of conditions which goes across generations, and it helps us to trigger referrals to relevant specialists in a timely fashion. Many diseases we know have a genetic component, such as some cancers, neuromuscular diseases, heart disease and diabetes. Early identification of these can guide screening and improve outcomes, and it can shorten the diagnostic odyssey for people with a rare condition. So that's the time it takes them to get a diagnosis from first presenting with symptoms. Taking a family history can also help identify and gives the opportunity to build rapport and trust, which also supports tailored screening and surveillance. So really what we're saying is if you build a rapport with someone, you're more likely to be able to elicit information with them, so they'll be able to share a little bit more about family history than you perhaps would have done if we hadn't been so open with our questions. If a family history is not taken, then relatives are less likely to be considered. So you could have a person in front of you who's got a half brother, a pregnant cousin, an aunt, who all may have an increased risk of a genetic condition, but because we haven't discussed that with them, they're not going to get that risk assessment. It also helps provide a space for questions and helps correct misconceptions to guide preventative care. As healthcare professionals, we're often being able to ask to clarify health misconceptions, and it's important as we live in an age where health misinformation is easily accessible, and we have a responsibility to provide informed care for our patients. In the case of preventative care, if we look at, for example, Lynch syndrome, this is an inherited form of bowel cancer. If we can identify other family members who are at risk, so they have inherited the same gene variant, but they haven't developed the cancer, then we can refer them on for screening and preventative measures, such as the use of aspirin to try and reduce that risk of cancer developing. It also, taking a family history can also support consideration of risk assessment for other family members to help inform reproductive choices and counselling needs. So if we think about couples considering a family, we can assess the risk of passing on inherited disorders such as cystic fibrosis, sickle cell anemia, or for example, in the case of a haemophilia A carrier, this information can inform their pregnancy care. Now, this is not an exhaustive list, but this is just some of the key reasons why taking a family history can really support clinical practice. And just reflecting back on the poll, as I say, we've got some really key points, and risk has been the biggest thing that's come up on there. And I'm just going to read this quote out to you from the British Society for Genetic Medicine. So taking a family history involves asking questions about each member of the family to determine how family members are related to each other, their biological relationships, and any medical conditions they may have. This information is usually gathered by asking a series of questions about each person in a family, moving from person to person in each generation in a systematic way. And I think this quote quite nicely sums up the information that we really need to gather when we take a family history and why it's important. You're on mute, Joe.
That's always a good start, isn't it? As a refresher, we really wanted to start with some of the basics, what might be a red flag within that family history. So one of the key telltale signs is when a patient starts highlighting conditions or signs or symptoms within a family that may be very similar. If multiple relatives are affected, it's suggested it's an inheritable condition, especially when it's within that first or second degree relative. This, however, might not be the case in something like an autosomal recessive condition, where the person inherits 2 copies of a gene variant, one from each parent. If you notice an early onset of a condition, for example, breast or bowel cancers below the age of 50, it might indicate a genetic predisposition. If you have a condition which is generally associated with the opposite sex, it can often be overlooked, but actually it's less likely to be due to chance or environment and is a significant red flag. And then clustering means that there's several people in the same generation or closely related who have the same condition. And this may be a sign that it's inherited because those relatives share genes. And spotting the kinds of pattern really helps doctors to figure out if there is a genetic cause. So what we want you to take from this, it's not just what the condition is, it's who has the condition, when it was diagnosed, and how many people. When we think about family origin, it can provide clues to that genetic predisposition. We know that in some populations, there are small groups of ancestors leading to a higher frequency of a certain genetic variant. And over generations, some groups may have also adapted to their local environment. We can take sickle cell trait as an example, and it's more prevalent in people from African or Mediterranean descent because of the protection against malaria. However, it's just to state this is a starting point and not a diagnosis. We must remember that whilst this may be more common, any person could be a carrier of a type of variation, and 2 people from the same ethnic group could be genetically very different. When we move on to consanguinity or close relative marriage, this is an area where it's indicated that there is a slight increase in that risk of recessive conditions. However, people in those close relative marriages do not automatically warrant a referral to genetics. You really need to consider if there are other genetic clues that indicate that referral, and if those couples even want a referral. If there's also a known genetic condition within the family, even if the patient themselves is unaffected, other members of the family or a pregnancy may carry that same risk or chance. And thinking about family history of developmental delay or learning difficulties can also be a clue of inherited conditions, even if it hasn't formally been diagnosed. And then going back and thinking of that theme of pregnancy, infertility, recurrent miscarriages, or neonatal death can signal an underlying health condition, especially when we think about that close relative marriage. And it's worth investigating what tests were previously offered to ensure care and future management is appropriate. And here we wanted to summarise that it's where someone is from and who they're related to can shape that inheritance risk. And then we also have red flags that might be staring us right in the face, but not necessarily associate with warranting further investigation. So sudden unexplained death, for example. I had a good friend and a GC once told me to really be suspicious of drownings or accidents of single, young fit adults into, car crashes into a tree or something like this, because further questioning about that family member could indicate a genetic cause such as a cardiac condition. Unexplained congenital anomalies or syndromes can, again, not always, reveal undiagnosed chromosomal or single gene conditions. And one of the biggest is linking in with what is happening to other family members. Are there any family members currently undergoing any genetic or specialist care? How could this affect your patient? And again, we want you to go away with this of trust your instincts. When something doesn't feel right, it's rare or unusual, there might be a genetic clue underneath. So with that in mind, we wanted to go through a couple of practical examples for you to reflect on. They're based around real events, but they are not real stories. During this, we're going to ask you, hopefully if your polls work, we're going to ask you some questions, and we really love for you to get involved. And again, the good news is it's anonymous, so you can just, put in as you feel, but don't worry about it. So our first case is Amira. Amira is 38 years old. She presents to her GP with worsening heavy periods and fatigue over several years, resulting in a disruption to her daily life. Her GP refers her to gynae. Imaging reveals multiple large fibroids, and during the consultation, Amira is asked whether she has had any relevant family history, and she responds no. Following an in-depth discussion about the options, she undergoes a hysterectomy. So, poll question. So I'm going to ask Ian to get this poll question up for us. How might a patient interpret the question about any relevant family history? So thinking about us as not professionals, member of Joe Public is being asked about their relevant history. What do you think they may take from that? Is it A, the doctor is asking if anyone in my family has fibroids or other similar conditions? Is the doctor wanting to know if any family members have cancers like breast, ovarian, or prostate? Or is the doctor asking if there's any known genetic conditions in her family?
Just looking at the poll responses at the minute, Joe, for you. At the minute, we've got 90% are 83% are going with question answer A, and 14% are on B at the moment. And fantastic. I think it's not moving, so I'd say that's where we're at.
Yep, no, that's great. Thank you, everyone, for getting involved. So, yes, I would say at this stage, Amira's symptoms and diagnosis of fibroids are the primary focus of that consultation. So it's reasonable for her to interpret that question about relevant family history as referring to conditions of fibroids or something similar. However, clinicians are often asking about family history to identify broader hereditary risks, such as cancers, which may not immediately seem connected to fibroids, but could influence that care and treatment decision. So really, patients may benefit from some clarification about what relevant family history entails to ensure they provide the most useful information. So what was missed? Aha! Her maternal grandmother died of ovarian cancer at 52, and her maternal uncle was recently diagnosed with breast cancer at 45, and these red flags were not documented prior to surgery. What happened next? Well, 2 years post-hysterectomy, Amira's mother is diagnosed with breast cancer. Her GP reviews the family history and uncovers those previously missed details. And Amira is referred to clinical genetics and found to have a BRCA1 variant. But by then, she is diagnosed with a high-grade serous ovarian cancer, highlighting the missed window of prevention. So we're just going to ask about the next poll. What red flags in Amira's family history should have been identified during that initial consultation? Or what would have prompted you to think about maybe a further investigation into that family history? So maternal grandmother died of ovarian cancer, male relation with breast cancer, both, so the grandmother and the uncle, or actually at that point this family history isn't significant and there were no red flags for you to think about.
At this point, Jo, we have 100% on answer C.
Lovely. Okay, that's great. We didn't want to make it too difficult. So yes, although, you know, it is a thing around that male relation with breast cancer, the fact that there were two relations, second degree relations, needed that referral. So that's brilliant. Thank you very much for getting involved with that one too. So, do you have any relevant family history? May sound clinically routine, but to patients it's ambiguous. Without clarification, they may think of only immediate relatives who are alive, in fact, benign conditions like the fibroids, or actually something they deem, you know, personal or important. So actually asking a little bit more, and had that family history been identified, potentially it could have prompted a clinical genetics referral, led to cascade testing, starting with her mother, who may have received that BRCA diagnosis sooner. Informed shared decision making around that hysterectomy, including the removal of ovaries and tubes to reduce that cancer risk for Amira. And then enabling genetic counselling and surveillance, even if Amira's own BRCA result wasn't yet available.
Lovely. So if we move on to our next case study, and this is Archie, and we're going to look at misclues in his family history. So Archie is a 22-year-old university student. He presented to accident and emergency with a sudden onset chest pain, shortness of breath and palpitations. He'd also got a history of fatigue building over the last few months. He was diagnosed with an aortic dissection requiring emergency surgical repair, followed by medical management. So we'll just pause Archie's story here for a moment, and we've got a couple more polls. Very simple one to start with. It's a yes/no question. So if you were the clinician seeing Archie at this point, would you have asked about family history? So this is just a yes or no in the poll. Thanks, Ian, for launching those.
I can already see those responses, Anita. I'm not sure if you can, but
I can't.
already
I can.
90% at yes.
Fabulous. Again, this isn't a judgment call. This is just we're trying to get into that process of, are we thinking about family history at every situation? Fabulous. Thank you very much. So if we look at our next question. So our next question is, which of the following family history features would prompt you to consider an increased cardiac risk in a patient? So we've got a grandmother who had heart failure at 85, an uncle who dies of a sudden cardiac event at 39, a stepfather with an MI at 58 years, so myocardial infarction or heart attack, D, all of the above, or E, none of the above. Lovely. Okay.
Interesting.
It is interesting. Yeah, just seeing that creeping up. Okay, now it's one again. It's there's no well, there are some right answers, but there's no definitive right answers here. So the grandmother at 85, we've ruled out because she's 85 with heart failure. It's not a risk factor we'd think of for immediate family. B, the uncle dying of a sudden cardiac event at 39 years. That's the correct answer in this case. The reason being is anybody dying of sudden cardiac death under the age of 40 should be raising a red flag. Now, interestingly though, some of you put all of the above. If we look at the stepfather who had an MI at 58, you're right, that would be consideration, but in this case, he's Archie's stepfather, so he's not a biological relative. However, in practice, you would be asking this gentleman about his other family members. So as I say, it's a little bit of a trick question. There's no right and wrong, but it's just to highlight that, being aware of the person you're dealing with and the family members in relation to them. So as I say, sudden cardiac death under 40 is a red flag, and any cardiac event in someone under age 60 is also something we would be considering as well. Lovely. Okay, so what was missed for Archie? So we've already sort of looked at this. Archie's uncle, age 39, so that's his maternal uncle because it's his mother's brother, died suddenly whilst playing football of what was the family was said was a heart problem about 10 years ago. Anecdotally, they mentioned that he was very tall, had scoliosis and was very myopic or short-sighted. So what happened next? So in reality, we know that aortic dissection in a young person, Archie at 22, that's extremely unusual. And the treating team were prompted to look for an underlying cause. The inherited cardiac conditions team referred Archie for genetic testing, where he was diagnosed with Marfan syndrome. And the family were, genetic counselling for the family was initiated. Cardiology will often refer on for this, and if the cardiology team needs support, you can involve clinical genetics at this point as well for those further discussions. So what should have happened then? So we've already mentioned that sudden death in someone under 40 is a red flag. So if further investigation had been undertaken when Archie's uncle had died, then family history might have been taken and we could have had some further clues which might have supported genetic testing. Now, in what we know now, that would have been enough for us to warrant further investigation. But with something like Marfan's, and Marfan's is an autosomal dominant inheritance pattern, which means that every child born of an affected parent has a 50% chance or a 1 in 2 chance of inheriting that disorder. And it's a genetic disorder which affects connective tissue, which is across all of our bodies, but primarily it affects skeletal, cardiovascular, and ocular systems. So the scoliosis of the uncle's back, being very tall, because sometimes people with Marfan's can be very tall with very long, thin limbs, being very short-sighted, and obviously the cardiac event are other clues. They're not definitive because severity of symptoms can vary between people. And so what is classed as a typical presentation isn't always observed in everyone we see. If the family had been picked up at that point, they would have been offered regular cardiac screening and they would have been provided with risk management advice.
So then our final case, Eva's story. Eva, 31, attends her first antenatal booking appointment. She completes a standard paperwork, which includes a brief family history tick box. She indicates no known genetic conditions and no further questions are asked. In this case, what was missed? Eva's partner had a baby from a previous relationship who died at 3 weeks of age from an unspecified enzyme disorder. And this critical detail was not captured because Eva was not asked about her partner's children. In fact, it was presumed that there were no other children. And as a result, this important aspect of that family history was not captured. And when Eva's baby Jonah was born at term, but develops vomiting and lethargy in the first few days of life. He's transferred to the neonatal unit and diagnosed with a rare inherited metabolic condition that is treatable, but only if detected early. And unfortunately, the delays in that diagnosis resulted in significant developmental impact. So again, learning points here, tick box history alone isn't enough. You need some open prompts that are essential. Has anyone in your family ever lost a child or had an unexplained condition? Family history isn't just about the birth parents, it's about the baby's full genetic picture. So, asking about the partner's children and family health can have significant implications. So, here, as we say, having that understanding within that family history could have revealed that inherited risk factor. And knowing that risk factor might have prompted specialist referral, prenatal counselling, and preemptive prenatal or newborn testing for Eva's baby. So this is just a reflective poll that we're asking. It's just whether you would have thought about asking about Eva's partner, I can't even say it, Eva's partner's other children. Because I think when I look back, I'm not sure I would have when I was newly qualified, because there's a lot of questions that you're asking. So it would just be nice to sort of have that reflection on what your thoughts are.
Just loading that up, Jo, at the moment. We've got a real mix of responses, actually, sort of quite widely spread across, apart from C, which has got the lowest response rate, but it's sort of looking at A and D are the most common there.
Yeah, and I think that's the point, isn't it? And that's what we're trying to get across is really just thinking outside of that. It's just the family vision. And I think, you know, with my own experiences of being a stepmother, it's you learn. I think you learn as you go along. So it's having those experiences. So yeah, thank you for sharing that. Okay, so now some practical skills, Anita.
Thank you. Right, let's look at how can we apply some of what we learn and some practical skills for in practice. So you've noticed a red flag. What next? You don't need to make a diagnosis. You just need to be able to recognize patterns and take the next step. Whether you're in midwifery, general practice, oncology, pediatrics, you could be that person that moves that family one step closer to answers and getting early support. There are some simple and accessible actions anyone can take, and you don't need to be an expert in genomics to do so. So if we look at this slide, this shows us a genetic pedigree, and this is a visual family tree that uses standard symbols to map medical conditions and relationships across the generations. This helps all healthcare professionals in all clinical areas to recognise patterns of inheritance, as some we've mentioned already, such as autosomal dominant, recessive or X-linked traits. Now we have a QR code on here, but we are sharing these in a slide at the end of this session, and we'll have links to all of these, so you don't need to worry about not being able to access it at the moment. But this QR code particularly will take you to the Genomics Education Programme, where they have a module on taking and drawing a family history. This gives you a much more in-depth understanding of all these symbols and lines, what they all mean and how to use them in practice. And this is really what a pedigree would look like if you'd had time to sit and draw one out for a patient. So this pedigree shows an example with 4 family members affected, and they're shown by the shaded in symbols on the pedigree. You can see how other health data has been added to each person on there, such as date of birth, date of death if applicable, and names of other family members. The person giving us this information is Julie Smith, and you can see that by the little arrow pointing at her. She may also be referred to as the proband, which is the first individual in a family identified with a genetic condition and who's sharing it with the healthcare professional at the time. And as I mentioned, this is a visual tool which quite neatly shows the pattern of inheritance. So just by looking at this, you can see all the family members that are affected in Julie's family, and it's quite clear. And if you have a look, as I say, at the Genomics Education page, it has a really good section about how to draw a family tree. And you can practice this when you're at home and do this for your own family. That's always an interesting way of doing it. So pedigrees, why are they useful to clinicians? Why do we sort of talk about taking this visual family tree? It helps improve referrals. knowing what information genetics team needs helps you to gather it much more effectively, and it can support the conversation. By understanding how patterns are interpreted, it can build confidence for when you're discussing family history with different family members, and it will enhance care because it will help you to be able to recognise when that patient's story might suggest an inherited risk. So even if we don't know what the condition is, we can see there is a pattern of inheritance, as we saw in Julie's family tree just a moment ago. So moving on from recording a pedigree, what if? So in clinical practice, we really appreciate how busy you are out there. So if you don't have time to draw that family tree, or you haven't got the confidence or the skills yet to do that, how can you incorporate some of this as part of your assessment skills so you can draw out taking that family history? So there are some questions you can ask, and just for a start, the first question you could ask is, can I ask a few questions about your family's health to help tailor your care? Do you have any concerns about illness or conditions that run on either side of you or your partner's family? Has anyone ever needed treatment in hospital or had a serious illness, operation, or a genetic test? As Joe mentioned earlier, in family patterns that matter, do you know if anyone in your family had any serious illnesses before the age of 50? These are all key questions that you can raise with your person or the patient you're seeing, which will just help draw out some of that information. So what could you record even without drawing? So as I said, we appreciate you haven't always got time, but what could you take down? What information is going to be helpful? When a patient is referred to genetic counsellors, they have to take a very detailed it's a very detailed conversation that they have. So what we're trying to do is put this into perspective of the details that you are required. If we as clinicians can glean some of this information, it makes the referral process much more efficient and smoother for everyone involved. So what could you record? Who is effective? So what is their relationship to the patient? Which side of the family do they come from? It's really important to highlight and clarify which side family members are from, such as maternal aunt or paternal grandfather, particularly when we're using terms such as cousin or aunt. What condition do they have? So for example, could it be breast cancer? Is it sickle cell? Is it muscular dystrophy? We do need to name that condition that we're looking or considering genetic testing for, and family history. Age at diagnosis and age at death, if known. And again, sometimes patients can't give you exact details, and that's fine. Just an approximate is always helpful. Ethnicity and consanguinity are really helpful if it's relevant to this person. And another key question is, has anyone else in the family had genetic testing? Because this can help identify and highlight specific conditions which are already being investigated. Sometimes people don't link things together, so it's just another question you can use to draw out a little bit more information. And you record all of this in plain language in the notes and as part of your referral. And don't worry if everything is not known. We just really want to reassure you to take your time at this point. Most people are patient with us when we say we're taking a history, and that they can see that it takes some time and some thinking about as we write down this information. But just by noting the patterns that we can see, this will really help the genetics team when they have to draw that pedigree and assess risk for that patient.
So we didn't want to go away from this session without thinking about that holistic care. So we just wanted a couple of slides just to emphasize this. So when we talk about family history, it's important to recognize that not every story fits the traditional narrative. Families are diverse, spanning cultures, structures, and lived experiences. And our approach to these conversations must reflect this. An inclusive approach starts with that empathy and openness, and it's about creating a space where everyone feels safe to share, especially when histories might include trauma, separation, or that non-conventional dynamic. Asking questions sensitively, listening without judgment, and being flexible in how stories are recorded or retold make the difference. And here's just a few examples that we have that could potentially help you in practice. So I'm not going to read them all out, but I'm just going to pick a few. So when we think about Eva's case about asking about children, instead of asking about do you have children, do you have any children, including adoptive or stepchildren, just to really make it inclusive. When we're exploring parents' history, tell me about your mum or dad. Well, there could be legal, biological, and social aspects of that mum and dad. So how about tell me about your biological parents' health? And then finally, thinking about a person that may be adopted. Are you aware of any of your biological family history? In that clinical conversation, we want you to be confident in the questions you're asking, but it doesn't mean knowing everything. I think it's impossible. I'd even probably ask some of those genetic counselors and clinical genetics teams whether they know every single genetic condition listed. But what we're asking is that you ask with care and interpret that information wisely. And when it comes to that medical relevance, our focus should be on the organs and inheritance and not assumptions about somebody's identity. And if you're really unsure about how to frame sensitive questions, consider just asking, is there anything about your family, the way your family was formed, that would be helpful for us to know? Because it's open, respectful, and puts the person in control of their story. We also know that from the ethnic inequalities in genomics and precision medicine report and broader research, that people from ethnic minority backgrounds are often underrepresented in both the genetic databases and clinical trials. And this creates disparities in care and risk compounding existing health inequalities. And one of those contributing factors is how that family history is gathered, or sometimes overlooked due to cultural misunderstandings. That's why cultural sensitivity is really crucial. So we should avoid making assumptions about roles, relationships, or values. We should think about language. It matters. So that steer clear of that jargon of terms that may not translate well across cultures. Also keep in mind that some cultures, having that discussion around family history can be considered as private or even taboo. So reassure individuals about that confidentiality and explain clearly why this information matters to their care. We must really acknowledge those cultural norms without imposing our own values on it. And then one of the other things is thinking about those translators if they're needed. Really, the ideal is professional interpreters, again, to ensure that there's that protection of accuracy of information and safety and comfort for those patients. And so some of those small changes could really assist with bridging gaps in care and fostering trust across communities. So unfortunately, we could have talked about this for a lot longer than 45 minutes, but we don't, and we have to end somewhere. So to close, there are 3 takeaways we want you to get from this session today. Number 1, always ask about the family history. A well-structured conversation can reveal crucial and even life-saving information, especially when it's inclusive and respectful of the person's background and lived experiences. Secondly, if you spot a red flag like early deaths, unusual illnesses, or features suggestive of a genetic condition, gather as much detail as possible, ask sensitively, and use clear jargon-free language to guide that discussion. Thirdly, know who, how, and when to seek advice. You're not expected to be an expert in genetics, but recognizing when to refer and act early makes a huge difference. And, we're doing a lot of mainstreaming at the moment, so it might not be that referral to clinical genetics. It might be an MDT discussion for that urgent screening, but ultimately timely action matters. And through it all, remember, inclusive and culturally sensitive conversations aren't just nice to have, they're really central to that equitable care. As Anita said, and you've seen along, there's been lots of QR codes. We've pulled together some of the tools. If you walk away from this and think, actually, I want to know a little bit more about those different inheritance patterns, how to take and draw that pedigree, and then linking in with the British Society of Genetic Medicine to give you some more key information. And then finally, I've added on selfishly one about genetic inheritance for the pregnancy pathway as well for those midwives that are on the call. There's a few references that we've used along the way. And I've just flipped back there. So the lunch and learns are being paused over the August holiday, but if you have enjoyed this session and you want to listen back to the previous recordings, there's a QR code there, and those sessions were around genomics and why it's relevant to you, and then also some of those I think red flags through the lifespan, so talking about ethics and research, which were both really excellent sessions. And then I think Ian's probably dropping in the chat that there's an event going on within Cambridge looking at CAN risk training, which is an online tool that enables healthcare professionals to calculate an individual's future risk of developing breast or ovarian cancer, so using that family history. So that will be a really interesting session. Again, Ian might have popped it in the chat already. We've got an evaluation. We'd love to hear your feedback. Your feedback helps us influence the future sessions. So it's really important that we get this right for you.
Lovely. I suppose I just want to say thank you very much then to everybody who's attended, and we really appreciate your feedback. And if you have taken time to fill in the forms, it's really helpful because that will inform what's happening for the next sessions, and it just helps us tailor what information you need. Some really interesting questions, and apologies we can't answer all of them, but if it's made you stop and think, fabulous. So thanks very much, everybody.